Hello everyone, I think we're going to go ahead and get started. It's my great honor to introduce Dr. Brandon Boyce. He has a very productive and distinguished career. He tried to send a CV to me, but it's tried to shorten several times. Eventually he sent me his bio-sketch, so because there's a page limit. So I think he also is an international traveler. He's been a research fellow at University of Alliance and also University of Texas, San Antonio. And then he decided to settle down in the United States and become an associate professor in 1990s at the University of Texas, San Antonio, and rise into full professor, and then moved to Rochester, became the pathology director in the University of Rochester. And then he became an AP director and then vice chair. But now he's an entrepreneur. He started his own company. And so he has more than 200 publications. He has our one's been funded for more than 20 years continuously to study the osteoclast in the bones. And he is a leader in pathology and also in research community. He's the president of the International Society of Bone Morphometry. And he's a great teacher and mentor. So I think he trained many residents and also mentored a lot of junior faculty. And I think some of the people he recruited as chairs in Duke and also the AP director in other universities. So please let's welcome Dr. Boyce.
Well, thank you, Fachan, for your introductory remarks and for inviting me to come and talk about not my research, but some clinical cases which I hope the faculty and residents might enjoy hearing. I was very happy to recruit Fachan to our faculty a few years ago and was not too happy when you guys recruited him here. On the other hand, I think you've got a gem in someone as a diagnostician and as a future funded researcher. So these are the learning objectives which I'll let you read. I've been studying osteoclasts since the mid-1970s, initially doing clinical work and looking at bone biopsy specimens from patients with metabolic bone diseases. And remember my chair asking me back in the early 1970s if I would take an interest in metabolic bone disease. And I said, what is metabolic bone disease? And it turns out it's studying how bone turns over normally and becomes abnormal in diseases like osteoporosis, Paget's disease, renal osteodystrophy, osteomalacia, and so on. And then in the 1980s, decided that I would like to learn to do experimental research, and that's when I went on a fellowship to San Antonio. So I'm going to describe our understanding today quite briefly of how osteoclasts and osteoblasts interact with one another as well as with immune cells to regulate bone remodeling. I don't have time to tell you about how bone cells can regulate other activities outside of the skeleton, and there are many of them, and how other organs regulate what happens within bone. It's a fascinating story that's been revealed over the last several years. And because I like osteoclasts so much, I see them when other colleagues of mine don't see them in lesions that we're looking at in conference. And I'm going to describe some of those as well as some of the advances that have been made in the last 4 or 5 years on molecular diagnosis of diseases. So at this time of the year, potholes start to appear in roadways, and by the end of the winter there are many more of them. And so there has to be a mechanism to fill in these potholes, dig them out and fill them in again. And the same thing happens in your skeleton. So these trenches are formed following signals from osteocytes within bone, telling osteoclasts to come along, dig a trench in an area of bone that's become damaged. This is then filled in by osteoblasts. And in a normal skeleton, you have this sort of appearance here, where you have a thick cortex and trabeculi are connected to one another. During aging, and especially after the menopause, osteoclasts become more aggressive. They dig deeper holes, and osteoblasts become less active, and consequently bone trabeculi or plates become disconnected, and you can imagine how this can easily collapse. They're derived from myeloid cells in bone marrow. These cells also circulate in the bloodstream and get attracted back into the bone marrow through signaling mechanisms. These cells fuse with one another, and they form sealing zones here, and then they have this ruffle border that gets formed, and the expression of tyrosine kinase is required for the formation of the ruffle border underneath the osteoclast. And under there, they secrete hydrochloric acid to dissolve the mineral and metalloproteinases to dissolve the matrix. And many factors can stimulate osteoclastic bone resorption. And several cell types, including stromal cells, osteocytes within the bone, and immune cells, can stimulate osteoclastogenesis by releasing cytokines. Osteoblasts, in comparison, are derived from mesenchymal cell lineages, and expression of two transcription factors, RunX2 and Osterix, are required for osteoblast formation. In the absence of these, you get a skeleton that's formed from in cartilage, and bone doesn't form thereafter. So some of the osteoblasts become incorporated into the matrix as it's being mineralized, and they reside there as osteocytes. And for many years we thought these cells didn't do very much, and their function wasn't clear. They looked as though they could remove bone around them in response to parathyroid hormone, a process that was described as osteocytic osteolysis. And it's now clear that they can do that indeed, and they respond in that way to parathyroid hormone-related protein during pregnancy, and this is produced by the breast epithelial cells. They also secrete receptor activator of NF-kappa B ligand, RANKL ligand. I'll describe what it does in a minute, as well as sclerostin, which negatively regulates osteoblastogenesis. So these cells are not sitting there stuck in bone matrix. They've got a very important regulatory role in bone remodeling. And it's become clear over the last few years that osteoclasts communicate directly with cells in the bone microenvironment. And this picture here, I think, can demonstrate how these stromal cells look as though they're interacting with this osteoclast on the surface of the bone. The precursors coming from the blood, they can fuse with these large osteoclasts, and they become bigger. The bigger the osteoclast, the more aggressive the bone resorption. So the biggest osteoclasts I see are typically in giant cell tumour of bone, and also in Paget's disease. And I'll show you examples of those if I've got time. And electron microscopic images of osteoclasts in culture show that they have these extensive processes that allow them to communicate with one another, with their precursors, as well as with cells in the mesenchymal cell lineage. And you remember that osteocytes can also communicate with one another, and they do this in response to mechanical stimuli and to other stimuli, will collectively release RANKL ligand, for example, to attract osteoclast precursors that can then cause osteoclastic bone resorption. And for those of you who, like most departments of pathology, are unable to do undecalcified plastic embedded sectioning to try and determine if a patient has osteomalacia or not, you can use this Tripp and Mackay method that was described in the early 1970s by immersing a piece of bone in silver nitrate overnight. The silver goes in through osteoid on the surface here, and if there is osteomalacia, the osteoid will be about this thick instead of this thickness here. So that's a cheap man's undecalcified method for determining whether osteoid is increased in thickness or not, and whether you may have osteomalacia. So over the last 20 years or so, it's become clear that osteoblastic stromal cells in bone marrow, as well as osteocytes more recently, express MCSF. These precursors of osteoclasts then, in response to that, express RANK, receptor activator of NF-kappa B. These cells also produce RANK ligand, diffuse and form these multinucleated cells. And there's a great deal of signaling goes on in response to RANK ligand binding to its receptor. This is from 2003, a paper that Boyle and colleagues from Amgen, who were among the first people to discover RANK ligand, as well as osteoprotogerin, which binds to RANK ligand and prevents it from binding to its receptor. So the balance between OPG and RANK ligand in the bone microenvironment is a major determinant of whether you will have excessive or normal bone remodeling. I'm not going to go through all of these pathways. We discovered a few years ago that NF-kappa B signaling is required for osteoclastogenesis. Later it was shown that NFAT-C1 involved in T cell development is also required, and so is C-FOS. SAP tyrosine kinase is involved in the motility and formation of the ruffle border in osteoclasts. So TNF also activates this signaling pathway, and we've been studying that over the last few years, activating expression or formation of P50 from its precursor. These go to the nucleus. P52 with REL-B goes to the nucleus. And what we've discovered is that this non-canonical signaling pathway is involved more in the increased osteoclastogenesis that we see in inflammatory conditions in particular, whereas the canonical pathway is involved in the very early stages of osteoclast formation. And it goes through activating C-FOS, then NFAT-C1 to enhance osteoclastogenesis. Now, one of our residents in the University of Rochester, Chen Zhao, when he was doing his graduate studies in the University of Tokyo, presented some data to me when I was visiting a few years ago that I couldn't make any sense of. And at the time, he couldn't make any sense of it either, but it was revolutionary. And that was that osteoblastic and osteoclastic cells communicate back and forward with one another. Up until that time, our understanding was that osteoblastic cells drove bone resorption, and it was a one-way process. And that was through activation of C-FOS and NFAT-C1 in here in the osteoclast precursor, promoting fusion and also promoting activation. And what Chen found was that there was also signaling through FB4 through efferent B2 into the osteoclast to negatively regulate this signaling as a balance. And you need balances for everything. And what he remarkably found was that reverse signaling through this ligand here negatively regulated osteoblast formation. And at the same time, there's a paper in Nature Medicine finding that this subunit of the proton pump also was required for fusion of osteoclastogenesis, and it inhibited osteoblast formation. And there have been many more examples, semiphorins being one of them, of factors that are released by osteoblastic cells that can positively or negatively regulate osteoclastogenesis, and other ligands, including Wnt's, that osteoblasts can release that can positively and negatively regulate osteoblastogenesis. Now, RANK ligand is essential for osteoclastogenesis, and there are some humans who've got mutations in RANK or RANK ligand who are osteopetrotic. But it's also involved in post-lactational proliferation it's not required, it's required for lymph node formation. So a knockout mouse does not form lymph nodes. Peyer's patch and T cell development is normal, but as we showed when we looked at NF-kappa B double knockout mice, there was a defect in full B cell development, dendritic cell development, and thymus development. It's also required for lactational hyperplasia following birth, and if this these knockout mice are unable to feed their babies because of that deficiency. It's also been shown to centrally control fever and body temperature in females and not in males, and that still is a bit of a mystery. It also promotes mammary cell proliferation and carcinogenesis and has been implicated in breast cancer metastasis to bone. And so using denosumab as an antibody that binds to RANK ligand is one of the ways in which they're exploring whether or not you can use this to minimize bone metastasis. It also has anti-inflammatory and neuroprotective effects in mouse models of ischemic stroke, in which it limits infarct volume. So I think we've got a lot more still to learn about this cytokine beyond these discoveries. And OPG also has other roles to play. It prevents arterial calcification, and so the knockout mouse has got calcification of renal arteries and the aorta. And then aberrant expression of both of these cytokines have been implicated in cardiovascular disease, diabetes, and hypertension. So those of you who do research in some of these diseases may find that looking at the signaling downstream from these will be important ways in which you could be trying to figure out how these cardiovascular diseases develop and progress. Okay, so that's some background on bone remodeling and our understanding of how it takes place today in a very simple version. To go back to bone loss with aging, osteoclasts, we think, erode through the full thickness of trabeculi like this in response to these and many other cytokines. And it's very easy then to imagine the bone becoming weaker and fracturing. There's also inadequate bone formation that makes the trabeculi thinner. And over the last few years, we've come to realize that in addition to sex hormone deficiency after the menopause, there is a low-grade chronic inflammation in aging that has been implicated in arteriosclerosis and Alzheimer's disease that also stimulates osteoclast formation and inhibits bone formation. And one of my R01s is to investigate the molecular mechanisms whereby low-grade chronic inflammation through NF-kappa B signaling leads to age-related bone loss. And we're developing strategies to try and prevent the bone loss that occurs as a consequence of this low-grade chronic inflammation, which we think occurs in response to increased expression of free radicals with aging. This is a picture of a bone that I took many years ago in Scotland, showing how these trabecular elements get lost. And it's very easy to imagine this bone crumbling, giving rise to the typical compression fracture that we see in patients who ultimately then can end up stooped over because of all this anterior collapse of vertebral bodies. There are more people get osteoporotic fractures, more women get osteoporotic fractures per year than they do get breast cancer, lung cancer, and die of heart attacks. It's a very common disease. Most people are unaware they have it, and as a consequence of bad press, bad press with bisphosphonate treatment, many patients and their physicians are unwilling to take bisphosphonates, which is a real sad tragedy. And so we're still looking for therapies that can inhibit bone resorption, which bisphosphonates do, but also stimulate bone formation. And we've got some preliminary data of a small molecule that we've identified which seems to be able to do both, and are investigating its efficacy in animal models of age-related osteoporosis and menopause-related osteoporosis. So bone remodeling during aging and normal life is going along at a fairly sedentary rate. In conditions like hyperparathyroidism, where we see osteitis fibrosa, this is the image that we see, lots of osteoclasts resorbing bone matrix, osteoblasts laying down new bone matrix, and fibrosis of the marrow. This marrow fibrosis is a reaction that we see when the stimulus to bone resorption is increased. We can see this in biopsy specimens from patients with chronic osteomyelitis, in many of the benign and malignant bone lesions that we see in response to bone injury or neoplasia. And what's interesting is that in hyperparathyroidism, despite all this very aggressive formation, notice that most of these trabecular elements are still joined. And we think that's because PTH, which drives RANK ligand expression by osteoblastic stromal cells, does not increase cytokine production in the same way as sex steroid deficiency does. And so in most patients with hyperparathyroidism, bone trabeculi remain connected. Okay, so I'm going to show you some cases which I have seen in the last few years where osteoclasts are present in lesions outside of bone. And if you can spot an osteoclast by its morphology, like these large cells in here, and here, this is a sarcoma that was diagnosed in Rochester a few years ago. And I spotted these osteoclasts, and when you stain them with tartrate-resistant acid phosphatase, they become very clear, and there are lots and lots of them. It wasn't very clear what kind of sarcoma this was, but the patient ultimately died of it. Here's a primary adenocarcinoma of lung with extensive osteoclast formation, which I saw in the last 2 or 3 years. Interestingly, some of these areas have got no osteoclasts associated with them, and some have lots. And here's a breast cancer case where half of this tumour had no osteoclasts and half of it does up here. You see there are lots of them in here, right beside an area where there are no osteoclasts. So I'm not sure what's driving the osteoclastogenesis here. It's very likely that the expression of RANK ligand and MCSF and other osteoclastogenic cytokines is taking place to drive this. And remember, the precursors are circulating in your blood all the time, and they can be attracted to these tumours and to other lesions by these cytokines being released by the tumour cells. And finally, here's a poorly differentiated breast cancer in lung with lots of osteoclasts in it. So if you look for these, you'll see them. If you don't recognise osteoclasts, you'll just sign the case out. Does it make any difference? I don't know. It's very difficult to study, especially if we don't see them. And then if you only see a few cases, it's very hard to go back and figure out whether or not these osteoclasts are helping, which they may be, or whether they're helping the cancer to grow, or whether they've got some other immunomodulatory role to inhibit the cancer cell growth. And osteoclasts are immune cells. They behave like immune cells. They are excluded from most diagrams that hematologists will show you. You never see an osteoclast in there. But recent studies have clearly demonstrated that these are immune cells. They release all of the cytokines that macrophages can release, and of course they're derived from the same precursor as macrophages. Getting a little closer to bone, here's an example of pigmented villonodular synovitis. It's been known that for many years that you can get osteoclasts from this and from giant cell tumour of tendon sheath. I'm not going to read all of that, and you probably won't remember, and neither do I, what these genes are. But studies published a few years ago demonstrated that there is a balanced chromosome translocation in this. So this is a neoplastic lesion where there's an increase in the expression of MCSF, a cytokine required for osteoclastogenesis. Giant cell tumours of bone, now we're into bone lesions. They represent about 5% of all primary tumours. Typically occur at the ends of long bones in 20 to 40-year-olds. And for many years, if you look back at the pathology literature, you'll see that the mononuclear cells look just like osteoclasts, and this was called osteoclastoma. I think many pathologists still do not recognize that this is a lesion of these spindle cells. It's a neoplastic lesion of the spindle cells, not of the osteoclasts. 80% of them are located in long bones. Some other examples radiologically of these lesions. And the stromal cells in these produce not only rank ligand, but IGF-1 and 2. They stimulate bone formation. Why that's going on isn't terribly well investigated. TGF-beta, IL-1, IL-6 are also expressed. So these are very busy cells, and of course the osteoclasts are also expressing these cytokines within this lesion. And what's amazing is that the osteoclasts really are only around the periphery of this. Like there isn't a piece of bone in sight here, and yet these cells are not dying. And it's presumably because of signaling between the osteoblast and these stromal cells. And osteoclasts are fairly short-lived, that is causing the proliferation and apoptosis of these. I don't have a picture of apoptotic osteoclasts, but when I was the first person to describe apoptotic osteoclasts in the 1990s, you see lots of apoptotic osteoclasts in this lesion. They're a bit shrunk, their nuclei are small, dark and rounded. And here's some studies from a paper in 2012 showing that these osteoclasts as well as stromal cells secrete a whole bunch of factors, some of which can stimulate bone formation. So a hematologist in Melbourne called Thomas decided that he would try treating patients with giant cell tumour with denosumab, which is an antibody, a human monoclonal antibody developed by Amgen, which inhibits osteoclast formation and activation and leads to osteoclast apoptosis. And he found that this eradicated the osteoclasts. And many of the patients had new bone formation in these lesions, suggesting that the stromal cell differentiation into osteoblasts is inhibited by the osteoclasts. So in the absence of the osteoclasts, these cells can differentiate into bone. And indeed, you can look at giant cell tumours and see lots of osteoid in some of them. Whether this is in response to microfractures or whether it's because the inhibitory effects of osteoclasts on stromal cell differentiation into osteoblasts is unbalanced, I don't know. Some lumicin and decorin, which are both proteoglycans, were commented on as being promising markers of giant cell tumours that might metastasize because the metastasizing tumours have lower levels of expression of them. I don't know anyone who measures these proteins or these proteoglycans in giant cell tumour specimens, but this is an indication of some of the research that's been going on clinically to try and better characterize these and figure out who's going to have a metastasizing giant cell tumour and who's not. One of the reasons for using denosumab is to try and reduce the tumour volume, inhibit bone resorption beforehand. And here's a giant cell tumour at the elbow, and the surgeon in the Rochester General in our hospital gave this patient denosumab before surgery. So the differential diagnosis of giant cell tumour includes a whole bunch of lesions, because many of these have got morphology that overlaps with giant cell tumour. And these include aneurysmal bone cyst, chondroblastoma, non-ossifying fibroma, and then giant cell granulomas that occur in the jaws and tubular bones of the feet. You may also get a biopsy from an Osteoclast-rich osteosarcoma and not see the osteosarcomatous part of it, and may be fooled into thinking that you're dealing with a benign lesion. And then high-grade sarcomas, of course, in the stromal cell lineage can arise in giant cell tumour. And if all you get is a piece of the benign part, you may not be able to make a definitive diagnosis. And there's been some considerable progress being made, particularly by Adrian Flanagan in London, who's published in the JPath Clinical Research a couple of years ago, that most giant cell tumours have got driver mutations in this gene. There's also a case of giant cell tumour in a G34L mutation, and then isocitrate dehydrogenase alterations were also discovered in 16 of 20 cases. And it's the absence of these mutations in other benign tumours, including these ones in which you can have lots of osteoclasts forming, shows that this is a mutation is highly sensitive and specific, so far at least, for giant cell tumour. Aneurysmal bone cyst, another osteoclast-rich lesion. It's great if you see hemorrhage and you see these serpiginous pieces of tissue within giant cell, or within aneurysmal bone cysts that are fairly characteristic. But you can get a piece of one of these that looks exactly like a giant cell tumour. These occur in the second decade of life, and these are the sites where they typically occur. Most of these have a USP6 gene rearrangement that can be detected during FISH. This was also part of this study that Adrian Flanagan reported. So these oncogenes identify the neoplastic cells in primary aneurysmal bone cysts and are absent in what are called secondary aneurysmal bone cysts that can occur in other pathologic lesions. Now, we don't test in giant cell rich lesions at the University of Rochester for any of this. Time will tell whether these will become useful clinically, and it will take some time to determine whether these have any clinical utility. But at least it shows that there are some soft tissue and bone pathologists getting involved in molecular diagnosis. And as Fachin and I were talking about while we were waiting before the start of this seminar, we need to figure out how to better classify lots of pathologic lesions. We give them names, we think we've done well, but DCIS that's going to be bad, or prostate cancer that's going to behave badly, we need to be working with our molecular diagnostic colleagues to try and figure out which ones are going to hurt patients and which ones you don't need to treat so aggressively. A paper in laboratory investigation showed that the CD14 negative, that's the stromal cells in aneurysmal bone cysts, express both RANK ligand and MCSF. They probably also secrete a bunch of other cytokines. Chondroblastoma, this is a rare benign chondroid neoplasm, and if you get a piece of the chondroid tissue from this, it's fine, you can easily recognize it. Most of them occur in the second decade of life in long bones and in the epiphyseal location. And here's one here. They may or may not have this rim of sclerotic bone around them, but they are occurring in the same sites as you get giant cell tumours. So if you see these cells, it's pretty easy to make a diagnosis of chondroblastoma. They're small, round, they've got very clear cytoplasmic edges. And if you see this chicken wire type of calcification, that's also a characteristic feature. But this is only in about 10 or 20, maybe 20% of cases will you actually see this. More often what you'll see is what you see in a giant cell tumour, plus or minus foamy macrophages. So molecular analysis of these, of 77, showed that they had this mutation in these genes, separating it from giant cell tumour of bone. And here's a small fragment of a chondroblastoma staining positively with an antibody to this mutant protein that was described just last year. So I think we're getting better able to characterize these lesions. And of course it's by being a bone and soft tissue pathologist in a centre where you get lots of cases, or you get lots of cases referred to you, and you've got time, and you're driven to try to do this, and you've got a good resident and fellow and so on, that can help us push the soft tissue field into the same league as solid tumours and hematopoietic malignancies. So finally, here's some examples of reclassification of aneurysmal bone cysts described by Adrian Flanagan. An 18-year-old female with a tumour, blood-filled vascular spaces, sounds like aneurysmal bone cyst, but this mutation was then detected in the lesion, and it was then changed to giant cell tumour with aneurysmal bone cyst change. Whether that makes any difference to therapy is unclear at this time. The second is a 22-year-old male, originally diagnosed as an aneurysmal bone cyst, both on X-ray and showing fluid levels in the MRI scan. But this mutation was detected, the histology was reviewed, and there were small areas with features of chondroblastoma, and the tumour was then reclassified. And of course, if a pathologist is looking at this lesion and it's mainly osteoclasts and there's just a tiny little focus of chondroblast-like cells, these small around, it's pretty easy to miss those. Non-ossifying fibroma also has got lots of osteoclasts in it. These are lesions that typically affect the metaphysis and diaphysis of long bones of children, but they do not have either of these mutations of this gene here. And so you could use either immunohistochemistry or FISH or other molecular studies to try and help make a determination. On the other hand, this radiologically is a non-ossifying fibroma, and the location and the age, so whether you need any of these molecular tests at this point is pretty uncertain. So you can get areas in this that are very typical with that storiform pattern with osteoclasts in them, and these often have areas of foamy macrophages, which are not so common in giant cell tumour or aneurysmal bone cyst, but still you get them. And you get these foamy cells also in pigmented villonodular synovitis. Okay, so the last case or type of disease I want to talk about is this one. This is a 55-year-old male with a history of prostate cancer, and he's got multiple hot lesions on bone scan in his ribs, spine and pelvis. And they took a biopsy of the ileum because it was the easiest to biopsy. And when you see hot lesions on technetium bone scans, and they're multiple, the differential diagnosis is metastatic sclerotic cancer. In a male, you would think of prostate. In females, it may be breast cancer. They can be osteosclerotic or Paget's disease. And what we see here is osteosclerosis. Unlike what I typically see in metastatic prostate cancer, these trabecular elements are really quite thick and sclerotic. You get a more weavy pattern to bone formation around metastatic prostate cancer. And if you look at this at higher magnification, there are no prostate cancer cells in here, and there are these areas of lamellar bone mixed with woven bone, which is very characteristic of Paget's disease. You also see this mosaic pattern of the cement lines that are pretty obvious if you know what you're looking for. And the large osteoclasts are very typical of Paget's disease, as well as that marrow fibrosis. So we've known for many years that there's lots of osteoclastic resorption and increased bone formation. You go through a phase of lysis and then sclerosis, marrow fibrosis. Biochemically, the most typical feature is an increased alkaline phosphatase with normal calcium, phosphate, vitamin D and parathyroid hormone levels. And studies in the last 10 years have identified mutations in sequestosome 1 gene, which encodes P62, is the most common genetic cause of classic Paget's disease and accounts for 10 to 50% of cases that are occurring in families, and 5 to 30% where there's no family history of Paget's disease. There are also variations in the osteoprotogerin gene, which appear to increase the risk of the classic form of Paget's disease, particularly in women, and why women and not men is not clear. And then mutations in RANK, activating mutations in RANK, the receptor for RANK ligand, have been associated and found in patients with early onset or the juvenile form of Paget's disease. So here's a bone scan of a patient with Paget's disease, and you can see that the knees are normal, but here in the scapula there's a lesion. and it's quite a large lesion in Paget's disease. It affects up to 6% of some populations, particularly in Northern Europe. And of course, people who have emigrated over here are carrying these mutations with them. There's a story that Dave Rudman, a colleague of mine from San Antonio, has been studying for many years, the hypothesis that paramyxoviruses are involved in the genetic mutations that occur that lead to increased osteoclastogenesis, and he still has NIH funding to study this, and has an animal model overexpressing paramyxoviruses in osteoclast precursor hematopoietic myeloid cells that looks a bit like Paget's disease. So that's still an ongoing controversy. These are pictures from patients that I was involved with in the 1970s and 80s in Glasgow. You can get quite severe deformity, bowing of the affected limbs. The one on the other side is unaffected by Paget's disease. This is from an autopsy I did. Patients can complain that they have to keep increasing their hat size because their head's getting thicker, or they may become hard of hearing because their foramina become closed off, or they may have deficiencies in their vision for the same reason. And finally, you can get sarcomas, particularly osteosarcoma, complicating Paget's disease. And this is an autopsy I did many years ago, and all of this tumour was completely dead by the time this patient died with metastasis. So I hope you have got a better understanding of how osteoclasts and osteoblasts regulate bone remodeling and keep our skeletons healthy. Their activities can become dysregulated in a number of pathologic lesions, some of which I've shown you. We can see osteoclasts in benign and malignant lesions, and there's overlap in osteoclast-rich lesions morphology in primary bone tumours, and some recent advances can help to distinguish among some of these lesions. And finally, that our understanding of Paget's disease at the molecular level has also been advanced in the last few years. So thank you for your attention, and I'll be happy to answer any questions that you may have.
Thank you for the presentation. Very interesting, obviously a very difficult topic. The practicing pathologist can relate to osteoclasts when we see them in mesenchymal lesions. But the difficulty, as you clearly pointed, is when we see them in carcinomas. You presented breast, you presented lung, we see them with undifferentiated pancreatic cancer, we see them in endometrial cancer, gallbladder cancer. And
sarcomas. Yeah, leiomyosarcoma as well.
Yes. So with the principle that you pointed out that not all osteoclasts are created equal, what is your vision as to whether we can or we cannot use their presence in carcinomas for subclassification? We already declared that we don't really know whether they have any prognostic significance. There's a push to call things metaplastic carcinomas when we see them, but do you see this coming for other tumors?
I think the short answer is probably not. And as I said earlier in my talk, they may or may not be seen as the first thing. So you could get a subset, a small number of pancreatic or breast or other types of cancers and bladder. I mean, they can occur in almost all tumours. Figuring out what the role is retrospectively without being able to identify that there are tumours that are going to have osteoclasts in them, that you can then get fresh tissue and do molecular analysis both of the neoplastic cells, the stromal cells, which of course play a very prominent role in all cancers, either supporting the growth of the cancer cells. Whether they are the cells that are pulling in the osteoclast precursors, the stromal cells, or the cancer cells themselves will require studies determining if it's the tumour cell that's producing, say, RANKL or one of the many other osteoclastogenic cytokines. that can cause expression of rank ligand in the stromal cells. And those stromal cells, of course, can arise from the same cell as an osteoblast and give rise to a chondroblast and a fibroblast. So there aren't enough people interested in looking at it is the first thing. Because if you're studying breast cancer, your focus is on the epithelial cell, and it may be on the fibroblast, and there's lots of studies today looking at these interactions between the fibroblastic cells and the cancer cells. Then you get this tiny number of tumour cells that also have osteoclasts in there. I think I'll be dead and gone and pushing up the daisies by the time somebody comes around to say, oh, these osteoclasts are actually doing something. Yes?
When you see osteoclasts in carcinomas or in undifferentiated sarcomas, is there a consistent zonal distribution to them? Do they tend to occur in the leading edge of the tumor or in the center, or are they intermixed?
So they can occur anywhere. Where I see them most commonly is their association with areas that are quite vascular. And by vascular, I mean there's lots of capillaries. And the place you see osteoclasts very near capillaries is in growing bones in mice and humans, right at the growth plate. They are very, very close to the endothelial cells that are all the time pushing into cartilage at the growth plate. So that's where I tend to see them. And as you saw in that lung cancer and in the breast cancer, they can be focal. So what is different about one part of these tumours and another? I've got a fellow coming, I think, from Saudi Arabia to work in my, or do soft tissue and bone clinically. And I may get her to see if she can get as many of these cases as we can and do molecular analysis of them. It'll be immunohistochemistry. But that's one thing that we could probably look at. Yes?
A number of years ago, I published a case of a patient with very extensive eosinophilic enteritis of a lot of the gastrointestinal organs. And there was quite a bit of extra-osseous bone formation. What role do the eosinophils play in this?
Oh gosh, that's a good question. I don't know. So it was bone formation and bone remodeling.
Well, it's bone formation outside the bone.
Yes.
In liver and other areas. But associated with the eosinophilic infiltrate.
Yeah. So mast cells have been implicated in osteoclastogenesis. I'm not aware of studies showing that eosinophils play a role in osteoblastogenesis. So the bone formation that we can see particularly in atherosclerotic lesions, if you look at enough sections of atherosclerotic vessels, you will see bone and bone marrow in those areas of calcification. There's some studies going on about how rank ligand and OPG are involved in the formation of the calcification as well as the formation of bone. And of course we also see bone in and around areas of previous inflammation and necrosis. But I don't know if eosinophils have been implicated in the the differentiation of the stromal cells into osteoblastic bone-forming cells. Yes?
I have a question regarding diagnosis of giant cell tumor. It is said that giant cells are diffusely distributed through the tumor, and the number of the nuclei more than saturated. What's your take on this?
Sorry, the number of nuclei is?
More than 30 or 50 or something like that.
Per cell?
Yeah.
I think that's kind of nonsense, frankly. So you've got this mesenchymal tumour that starts to grow and proliferates and is releasing cytokines that are pulling in osteoclast precursors from the circulation, and they fuse and then they start to destroy the bone, and so some of them are over here destroying the bone, In some areas, I can see in giant cell tumour it's predominantly storiform pattern of proliferation with an occasional osteoclast. The nuclear number, I mean, I shouldn't say this, but if all you've got to do is to count nuclei in osteoclast in a giant cell tumour, you should maybe think of studying something else. It's one of these things, it's the same in these textbooks, that, you know, if you look at the nuclei, the morphology is exactly the same as in the osteoclast, and therefore it's a tumour of osteoclast lineage cells. These guys weren't looking at the spindle-shaped cells, they were just ignoring them, and those are the tumour cells. Why the osteoclasts become so big and they're not near bone is to me what is intriguing, and it's the same thing as I showed you in some of these tumours. They're short-lived cells, they turn over, you can see lots of them dying in these lesions, and of course most of you probably don't recognise an apoptotic osteoclast when you look at these, but I think next time, those of you who do bone and soft tissue, you might say, oh God, that's what those things are. When I was learning to do basic science in the 1980s, 86 in San Antonio, interleukin-1 became available as a cytokine for investigation. And so I got a boatload of this and for the first time, and was investigating how it stimulated osteoclastogenesis in vitro and in vivo, and developed a model to inject it over the calvaria of mice. And we get these osteoclasts the size of this room, resorbing the calvaria. And then there are these really odd-looking osteoclasts that I didn't know what to call them, but they were apoptotic. And I'm taking pictures to try and get rid of these funny-looking cells because I knew they were funny-looking. But I didn't recognise it as apoptosis. More intriguing, apoptosis was first described by 2 Scottish and 1 Australian pathologists in the University of Aberdeen in Scotland. They published a paper in Nature in 1972, and then 2 of them moved to Edinburgh. I'm in Glasgow. There's rivalry between people in Edinburgh who are terribly, terribly posh, whereas those of us in Glasgow are not. So my mentor, who was a fabulous and best morphologist in Scotland, he said, this apoptosis, Brendan, it's just hogwash. You don't have to bother about that. We've been looking at apoptosis for years. So I thought, oh, Fred must be right. So I recognised these funny-looking osteoclasts in 1987. And it wasn't until I went back to Scotland for a couple of years and then came back. And then Dave Rudman was making a transgenic mouse using T antigen to drive osteoclastogenesis, and here are these osteoclasts the size of this room with mitosis in them, and all these apoptotic osteoclasts, and then the penny dropped. I thought, oh my God, I can't believe I didn't recognise this. So I didn't publish a paper on apoptosis till the mid-1990s. So I think if you look, you'll see, it's a bit like H. pylori. I looked at that for years and years and years, like everyone else, and never saw it.